zone is the Rampara health zone. And you look at the epidemic curve, you can see that we have a severe peak. We have a zigzag curve. And when you look at, for example, the Bunia one, it's similar to them. It can see that we have a sustained community infection. It is a sustained community outbreak that is ongoing in there. So as I mentioned, the most affected health zone are Bunia, Rampara, Mongwalu, Nyankonde, and they have the highest number of confirmed cases. And you can see that we have a various peak of the outbreak. So if you look at the distance between each peak, you can see that you have an incubation period of the outbreaks that I can maintain, I can say the hypothesis that the transmission is in the community. Next. When you look at the distribution of case by age and sex, you can see that men are, I can say slightly more affected than women. And the age group, the most affected age group is between 30 to 49 years old. That means it's really, I can say, the active population that is being affected. This can be explained by several factors. This outbreak is happening in a very highly mining zones where we have a lot of workers doing manual work in those mines. And when you look at also the depth, next slide. Okay, so exactly, thank you. So when you look at also the trend by health, I can say by age, when we make it a stratification of the age group, you see that the disease mainly affect the Ituri province and primarily impact young adults, although the age group can be, all age group can be affected. So when we look at the death, who is dying more? So when you look at that data, we see that living and disease cases have relatively similar age distribution. And most affected individuals are young or middle-aged adults, and especially between 20 to 45 years old. And the deaths are not limited to older people. They also occurred in young adults and in some cases also in children. So we cannot say that elder people are more affected than young people. So far, the distribution and the trend that we make the analysis seems to have the death age in the same group of affected people. Next. So now we will look at quickly the situation in Ituri province. Ituri, because we do that zoom, because when we disaggregate the data by province, it will show you different picture, which is really important to understand the dynamic of the outbreak. As I mentioned, in Ituri, we are having an average of 25 cases, confirmed cases since the last, 7 days, every day. The outbreak has evolved quickly, and the cumulative cases only in Ituri province is 518 cases, and the confirmed death is 80. That give us a case fatality rate of 15.4%. And as I mentioned, more than half of the territory is already affected by the outbreak. Next. So when you look at the province of North Kivu, on the date of 8th of June, they have an average of 2 to 5 confirmed cases a day. And the cumulative confirmed case they have is about 29 cases so far. But when you look at the death, is very high. They have 20 cases of death. That means the outbreak is really detected with a lot of delay, is detected very late. All those people that surveillance is being captured in the community is very late. And the case fatality rate in the North Kivu province is the highest one, so far it is almost 69 to 70% of the case fatality rate in the North Kivu, and we have 7 on the 35 health zone affected in the North Kivu. That means the outbreak is still very localized in some health zone, but however, we still also have a silent health zone that where we need to strengthen the surveillance. Next. The most stable province is the South Kivu. So far, the South Kivu, since the declaration of this outbreak, has a number of confirmed cases of only 3. And it is only one health zone under the 35 that is affected. So far, we have only 1 death in the South Kivu that give us a case fatality rate of 30.3%. So, however, what happened in South Kivu, it's one case, all the 3 cases are linked. So we have the epidemiological link. What is different in the other province that we are still need more investigation in order to establish a concrete transmission chain of this outbreak. Next. So we cannot talk about this outbreak without mention the security situation in the Ituri province. So on my left, you have all the arms group operating in that zone. And in my right, you can see the cartography, and you can look at where we have the most cumulative confirmed cases are the same place where we have also the armed group operating. So far in this outbreak, we have registered more than 520 security incidents that really, impacted the work of the teams in the field. Next. So I couldn't finish this presentation without a reminder that this outbreak is, evolving in a humanitarian context, and this situation has been there for long. So if you look at the map, you can see all the places where we have people in need of humanitarian situation. In DRC so far, the total population is 100.2 million of inhabitants. In Ituri, we have 4.8 million of inhabitants, and between them, we have 1.2 million that are population in humanitarian assistance. In the North Kivu, we have 2.5 people in humanitarian need. So that means the Ebola comes in a situation where the population was already suffering for so many other issues. They have insecurity, malnutrition, food insecurity, and so many, I can say, challenges also posing a threat to their life. And we shouldn't forget also to say that malaria remains the leading cause of illness in the eastern province of DRC. So reason why that this response of outbreak is, I can say, is a holistic response, taking into consideration the need, the health needs of the community, affected community, but also make sure that we have a good continuity of services so population can continue access to the healthcare that they need. I think this is the last slide for me. Next. So the situation in Uganda remains unstable. In Uganda, they don't have any confirmed cases in the last 24 hours. And the cumulative case they have is 19 cases so far. And they registered also 1 probable case. And between the confirmed case, they will have 2 deaths for a case fatality rate of 10%. So far, they have also 5 healthcare workers who has been infected that represent 25%. And the good things also in Uganda is that the transmission chain is very well known. So all those cases are happening are linked because the healthcare workers who are infected are also linked. There are those giving care, providing care to the case arriving from DRC. Between those cases, I have to mention that 14 of them are imported from the Democratic Republic of the Congo, and only 5 of them are producing locally in Uganda. So far, they have 4 recoveries. That's also, 80%. Next. So when we look at the data regarding the sex and distribution of cases in Uganda, you can see that we have 6, I can say, the female affected. They are between 51 to 16 years old. And we also have a 5 men affected, and they are between 31 to 40 years old. So that's also sustained the same, I can say, the same pattern in DRC. The median age in Uganda of the affected cases is 43 years old, and the age range varies between 17 to 59. Next. So the distribution of cases in Uganda and DRC, they have 2 different, outbreaks. In Uganda, the cases are really limited to some, I can say, healthcare centers. It is not at all a community outbreak. While in DRC, it is a very distributed community transmission, which is a maker this, the strategy to respond to that outbreak are also very different. In this cartography, you can see the healthcare workers where the cases from DRC has come in Uganda to seek for care. People are looking for care when they come to Uganda. So district with confirmed case, only 2 districts are confirmed case in Uganda, and also in 9 health facilities, which means it is a very located, I can say, outbreak in Uganda.
Thank you very much, Red. Thank you for that wonderful overview. As you can see from the emojis, it's been much appreciated. And thank you also for making the time to join us and share the situation with people from all over the world in spite of being so busy with the response. I now invite Dr. Patrick Otim to give an overview of the disease itself, the Bundibugyo virus disease. Thank you.
Thank you very much, Supriya. Good morning, good evening, good afternoon, colleagues, and thanks to my boss, Dr. Marie-Roseline, for quite eloquently explaining where we are in terms of this outbreak. So my work is then just to lay a bit more foundation. So what is it that we are dealing with when we talk about the Ebola diseases in general, but the Bundibugyo virus disease in particular. So just a second. All right, I was moving something out of my view. So as we know, Ebola disease generally is not new. I think we have been dealing with this for some time. We know that the first outbreaks were identified. We had 2 twin outbreaks in 1976, where the eldest of these viruses, that's the one we call EVD, which is the Ebola caused by the Zaire species, was first identified, simultaneously in DRC and in the southern part of Sudan, which is now South Sudan.
Sorry to interrupt you, Patrick. Could you put it on presentation mode, please?
It is presentation mode from my side.
Maybe if you could go to the top, if that's showing. And
let me share. Let me go then. Let me stop sharing and do it again. Apologies for that. Just a sec. Should be able to sort it out. Please confirm it's better now.
Yes, now it's working. Thank you so much.
Okay, thank you. So in general, Ebola disease, which is the name we use to refer to all the diseases caused by the different species of the ortho-Ebola viruses, is a very severe, often fatal disease. And so far we have had 3 of the 6 species of the virus that have been associated with outbreaks. So that is the Bundibujo virus, which we're dealing with currently. We have the Sudan virus, and then the Zaire virus. And when you look to the table on your right, you will see that the Bundibujo virus has only caused 3 outbreaks. So the first outbreak was in 2007 in the Bundibujo district of Uganda. And then you had 2012 in DRC, in Isiro, and now this particular outbreak that we are dealing with. So just to talk about transmission. So how does the transmission of the Ebola viruses in general, how does it happen? And as we know, Ebola is a zoonotic disease. So we have the initial circulation of the virus among the reservoirs. And for this virus, we have known that the reservoirs are the fruit bats where the virus circulates. And then from these reservoirs, we have the intermediate host or the epizootic host, from whom now it can be either gazelle or the non-human primates that get exposed to this virus and they become infected. From them, then one of these animals either becomes sick or dies, and then a human being comes in contact with them. And then we have now the primary transmission from the epizootics that's happening in the animals to the human. And this index case is usually either a hunter, a farmer, someone who comes in contact with this animal. Then from here, we now have the human-to-human transmission, which is amplified in different settings. So in households, in the healthcare facility, as Dr. Marie-Roseline was mentioning in Uganda. So this secondary transmission is amplified in those care settings where we have now sustained human-to-human transmission happening. So this is largely how the transmission happens. So who are the people at risk? As has been mentioned, so the people who care or who come in contact with the sick or dead animals in the forest are they really people at initial risk of the primary transmission. Then we have family members or caregivers, those who are really in close contact with people who are sick with Ebola virus. And it's usually somebody who is symptomatic who is able to transmit the virus. Then we have healthcare workers, those who are providing care with inadequate personal protection. Those are the ones at high risk. The laboratory workers that are handling specimen, and people who are handling bodies of people who have died with Ebola. So in people who work in mortuaries or different settings. That's why during Ebola outbreak, we emphasize on having safe and dignified burial that is done by people who have been trained. And then traditional healers or people who practice alternative medicine. This can also include religious leaders, people who pray for those who are sick. They would also be at risk because it involves them coming in contact with a sick person. So what is the incubation period for the disease? As we have known, it's 2 to 21 days. And I would like to emphasize that someone who is a contact, that means somebody who has come in contact with a person who is sick with Ebola, they will take between 2 to 21 days to develop the symptoms. They can only transmit the disease once they have developed symptoms. They don't transmit in the during the period of incubation, so when they are symptomatic. And what are the symptoms? So the initial symptoms are usually non-specific, and that's one of the reasons why for healthcare workers, it's very, very challenging to pick these up in the early phases. So you have sudden onset of high-grade fever, usually 38 up to 39. You have extreme fatigue. You have muscle pain, headache, you have sore throat. In this outbreak, we have also seen rash, skin rash, and these symptoms are non-specific. So it can pass for any of the tropical diseases, malaria, typhoid, and all these things. So you can think that it's not Ebola. Then progressively, some of the patients then enter the wet phase of the disease. So you have vomiting, you have diarrhea, and because of the impaired circulation, people then developed impaired kidney function, liver function begins to falter, and then some of the patients do develop bleeding. So For Bundibujo, what we see that bleeding is in a lesser proportion of patients, as you would see in the Zaire Ebola species and the Sudan Ebola species. So among the three of them, bleeding tends to be less in this one. And you see more of these other presentations, a lot of the diarrhea and vomiting, the impaired renal function, the impaired liver functions. And those are some of the things that would not really click in the mind of any clinician that you are dealing with a potentially very highly infectious disease. So that is a challenge in itself in terms of the diagnosis. So the potential patient history is essential. History of contact with a dead animal or sick animal, history of contact with a suspected or confirmed cases, or history of travel to an area where you have active outbreak happening. I'd wanted to show you this, which is right from the data that is being picked from the field right now. It may not be very clear, but if you see in terms of the occupation of the cases that we have, a lot of the cases, 35%, among housewife or people who caregivers in the home. That's the first group there that is most impacted. This one here, those who expression is not known, but you have then healthcare workers at number 4 there. So it really spreads a lot in that context of caregiving. But I also wanted to show you in terms of the symptoms, when you look to the right, that patients usually present with a combination of symptoms. So you have intense fatigue is the first one here. You have fever, you have nausea and vomiting, you have loss of appetite, you have diarrhea, you have headache. So these are the common symptoms that we are seeing in the patients that are presenting currently in DRC. And usually, so this combination of symptoms is important to pick, but you can see that the most combination is severe fatigue, fever, nausea, vomiting, loss of appetite, and diarrhea. And this is really non-specific for any clinician, and presenting more challenge as to even why this outbreak was detected a little bit late. So what does good outbreak control rely on? So one of the things is really empowering the community to understand how the disease is spread, adhering to the outbreak control measures. As then we have seen, surveillance and contact tracing becomes very, very important at this point, so that you identify a case early on, list the contacts and follow them for 21 days, and ensure that you can be able to quickly isolate them if they develop symptoms. The laboratory support for confirmation. So because of how the symptomatology it mimics most of the common illnesses, the laboratory confirmation becomes a very big determinant for you to be able to classify somebody as a case and non-case. That is the reason why in this outbreak at the beginning, we had a very high number of suspected cases when the laboratory capacity was low and we are not catching up with the identification of suspected cases. Because if you go to any facility and say you have fever, headache, diarrhea, vomiting, come this side, you will pick a lot of patients who have those. And that is really one of the explanations. So the case management, the infection prevention and control, and the safe and dignified burial that I mentioned are very, very key determinants. So how is the diagnosis done? It really requires the RT-PCR. Now we have some smaller platforms like the RADI one that is being used in DRC, which is undergoing validation, but also serology can be able to identify retrospectively whether this person had converted, so testing for the antibodies. The issue of the biosafety and biosecurity is key in terms of handling the samples, and also making sure that the clinicians who collect these samples, the healthcare workers who collect these samples, are really well trained. So we can collect the blood for this RT-PCR testing, or we can collect swab if we come across somebody who has already died. Then a swab can be collected for the PCR testing. How do we care for Ebola patients? Now, this is very, very important. The chances of survival from Ebola improves with early intensive supportive care, what we call optimized supportive care, and it has to be aggressive. So you see that a lot of the patients are presenting with diarrhea and vomiting and loss of appetite. So you need to aggressively manage the fluid balance, the electrolyte balance, monitor the vital signs very closely, and continuously manage this patient around the clock. Of course, you need to manage the high-grade fever that they have. You need to do other supportive drug therapy. Sometimes some patients have co-infection, either with malaria because we are in the tropics, or other bacterial infections that are superimposed on this. So you need to be able to manage those and manage the other symptoms like vomiting and the rest. So it's really critical that the person presents early, before they are actually in the wet phase, so that you can do the fluid and electrolyte balance management before they develop complications such as the renal failure or even kidney, liver failure. So that's really one of the things. So currently we do not have for the Bundibujo virus specific approved therapeutics, though we do have for the Zaire species, and we also do not have an approved vaccine. However, there are candidate therapeutics under consideration now for trial, and also there are candidate vaccines that are being considered. And we are hopeful that in the next few months that we can have candidate vaccines that can be rolled out. There are therapeutics that are under consideration, and clinical, the protocols for clinical trials are already being worked on with the governments of DRC and Uganda that can then be able to assess whether those therapeutics are effective. Now, the strategic pillars for effective containment and prevention include really a strong national leadership to, as Dr. Marie-Roseline has mentioned, to organize and coordinate that response, ensuring that we reduce the human-to-human transmission, having early detection and isolation and safe care, and also one health-based approach to ensure that we are preventing spillovers from the wild and ensuring that we have very good coordination with our colleagues from the animal health side in terms of monitoring the zoonotic spillovers. So I've mentioned about the issues of the vaccine, so I will not go about, but what I wanted to emphasize here, why is this outbreak concerning? Some of you did mention that one, we don't have a licensed vaccine to date for BVD. We do not have approved therapeutics for it. And some of the issues that was picked from the epidemiology is that we had a late outbreak detection. We have multiple locations in the Ituri where the outbreak is spreading with more than 50% of the health zones. We have a weak health system. Some of the community misunderstanding and beliefs are also challenges. We are in a world of disinformation. So there's a lot of infodemic and misinformation and disinformation, which is complicating the response. And also some logistical challenges, insecurity, humanitarian crisis. All these make this current response a very big challenge. So what is the takeaway message? One, Ebola disease is not new. The transmission can be prevented. It's not like COVID, which is airborne. So if you don't come in contact with a person who is symptomatic with Ebola, you do not get it. So when we adhere to the public health and social measures, it's possible to stop the transmission as we have done before. You know, in DRC, we had an outbreak last year that was contained within 87 days, but it was due to another species of the virus. So it's possible to contain this. Early detection is key, and separation of those that are exposed. So the cases from others is very key to stop the transmission, but also monitoring the contacts, because the contacts are the next cases. So it's very important to monitor them closely and ensure that if they develop symptoms, it's identified early and they are isolated. For the sick, early presentation at a treatment facility produces better outcomes. And we've been emphasizing that when we say that there is no specific cure for the disease, it doesn't mean that the person should not come to a health facility. We have already seen in DRC, 16 people have recovered already. And then in Uganda, also 5 have recovered. So this supportive care is working. And then the issue of communities need to own and lead the response, because a number of these interventions, contact tracing, active case search, all of it, the prevention measures, hand washing, avoiding participating in unsafe burials, all those things are things that the community needs to own and then take lead in implementing. Of course, strengthening of the health systems to deliver the care that's needed, but also ensuring that there's no disruption in the routine care, the essential health services, because more people will die from malaria and measles in DRC if we don't ensure that the delivery of the care is sustained during this Ebola response. And of course, the issues of ensuring that the health facilities are safe to deliver the care, they are supported with a solid infrastructure and funding. And then lastly, the government and political leadership that brings all of us as partners together and with the communities so that we can be able to stop this outbreak. So that, Supriya, was my last slide. Thank you very much, and we look forward to interacting with the audience. Thanks.
Thank you very much, Patrick, for that very comprehensive overview and those key takeaways, several very important points there. Community ownership, strong health systems in place, the government, political leadership, all very critical. I loved what you said in one of your slides, having a sort of closely intertwined and coordinated approach is very important. Now we have the overview, but many of you are wondering, what about in those countries that have not had cases? What should we do? What are the recommendations? So we have with us Dr. Ninglang Wang, who's the head for border health and ports of entry, and she will be giving the overview from that perspective. Over to you, Ninglang.
Thank you very much, Supriya, and thank you so much also for the comprehensive overviews that presented by Dr. Mary Roslyn and Dr. Patrick. This gives a very nice background and context of the outbreaks that may help you also to understand where this travel related recommendation come from, what are the rationales. So I will take you through the temporary recommendations from issued by WHO Director General that was issued the 22nd of May, and then how that interpret into the messages for individual level. So for the next 8 minutes, I'm going to just take you through all these key messages. I will start, as mentioned, the temporary recommendations issued by the WHO Director General. So we have the hyperlink at the bottom of the slide, so you will be able to access all the informations, all the recommendations that come across different technical pillars. Here, I would just highlight all those measures recommended for the border health points of entry related to international travel. So if you see the recommendations, the countries are classified based on their risk levels for 3 groups. So I would just go group by group and to highlight the key actions required for the different group of the countries in terms of border health and the POE. For the first group of countries, which are the the countries with the current virus detection. So these are the 2 countries, the Democratic Republic of Congo, and Uganda. So for this group of countries, the focus is really to contain the containment of the sources. So basically to prevent the exportation of the virus. The key activities as per the temporary recommendation is to avoid the cases and the contacts to travel, unless the travel is part of the medical evacuation. The second activity is to implement the exit screening, because at all points for entries, I see already in the chat, some of the participants are asking the exit screening at all points of entries of this group of the countries, because this could help to prevent the international travel of the cases and the contacts where they are supposed to be isolated for cases and contacts under monitoring. This also helped the travelers that departing from those countries and to go through the health evaluation to see whether they have the symptoms compatible with the disease and whether they have the exposure history. And then prevent cross-border movement of human remains of diseased case unless this authorized through the bilateral arrangements. So you will see those are the activities, are the similar philosophy is really to prevent the export of the exploitation of the risks and to make sure the containment of the virus at the sources. The second group is the neighboring countries. That are the countries that have land border direct connectivities with the first group of the countries. So for this group of countries, the focus is readiness, to keep ready for a potential importation. Now, when we say keep the readiness, it doesn't mean close the borders. So for the group of the countries, when we say the readiness is really to ensure that the borders are still open, so the social economic life are not disrupted, and then So no denial of entry to travelers and the convenience arriving from those first group of the countries. And then make sure the travelers are sensitized to the risk of disease and how to protect themselves and their families. So that include protect themselves and minimize exposure to the virus. So that including the discouraging themselves from traveling to areas with documented virus detection. And then for the borders at the points of entry, for this group of country, the focus is really to strengthen the detection, the surveillance at the borders, and timely management if there's of the suspected cases, if anybody is detected at the borders, and enhance the cross-border information sharing. The third group of the country is the rest of the countries. So for this group of countries, they do not have the direct land border connectivities with the first group of countries. For them, they are more on the preparedness status. So same, keep borders open, no suspension of flights, and no denial of entry to travelers and convenience arriving from the areas with virus circulation, because at this moment, the global level risk is still low. And provide the travelers with information, as we mentioned for the second group, it's always very useful. The travelers are fully aware of the disease and the risk of transmission and how to protect themselves. That includes, again, the discouraging them from traveling to the areas with documented virus detection, and providing the incoming traveler at points of entry, especially for those just coming, arriving from the areas of virus detection, so they understand what type of the actions they need to take if they develop symptoms within the 21 days after travel. Next slide, please. So having said that, that set of the recommendations are the recommendations for the countries, for their national health authorities, so they can take a customized into the national context and provide the information to their travelers and to manage the the actions that need to be taken at the borders. Now, how does that impact an individual? Because where many are, I assume many of the participants here, you come with some questions for, how that travel decision should be made on the individual level. What are the actions that you need to take, or what precautions you want you to understand for the individual travel? So here are the questions, basically the messages that we have developed together with our risk communication colleagues, and to facilitate, you have informed the decision in relation to travel. So here are a few messages. If you have question on, like, if you are traveling from areas where the Buju virus is circulating, first and the foremost, travel only if you are completely well. So that's the measures, that's the message that you need to take, and first to protect yourself and protect your families and the people you love. So expected the health screening at the departure. As we said, the exit screening has been implemented progressively at all the points of entry of the affected the areas. So that means you may need to anticipate some extra time for passing through the borders, because the temperature check or filling public health information form, this may take you extra time. So just to prepare your travel, you have that in your mind, and that might take the extra time than usual. And you may be asked to share information about your house and monitoring your house 21 days after arrival. Once you arrive in the destination countries, you might be asked that information and at the borders. Then if you travel to areas now currently with documented the virus detection, although we said in the first slide, in the temporary recommendation, the travel to those areas with documented viral detection is discouraged However, for many other reasons, if this travel is unavoidable, how to protect yourself. So first, to have that key messages that you see on the slides, avoid contact with people with symptoms compatible with the disease or who may have died with this disease. Monitor your travel for 21 days after travel. So these symptoms, Dr. Patrick has also specified in his presentation, the fever, headache, body ache, muscle pain, fatigue, loss of appetite, vomiting, diarrhea. So any of the symptoms, if you feel after the travel you have this type of signs and symptoms, please seek your medical care and mention your travel history. And also stay reachable if contacted by health authorities. It's likely if you are in the buses or in a crowded space, which turn out to be at the same place with our confirmed cases. Based on the risk assessment of the national authorities, you are identified as a contact. So you may be contacted by the health authorities. So please stay reachable if you will be contacted. And then if you are traveling to or living where the virus is not circulating, this means travel normally. However, stay informed because the situation involves quite quick. Understanding right now the risk of transmission at the global level remains low. However, it's always useful to stay informed and looking at the health messages and the entry requirements from the official sources, official websites, the Ministry of Health, Ministry of Foreign Affairs, or Ministry of Immigration, to understand, what you might anticipate when you arrive. Next slide, please. Now that brings my last slide. It's kind of the rules of thumb. Regardless where you travel, it's a good health practice whenever you travel, wherever you travel. Also protect yourself and others during travel, meaning consistently apply the health practice, the health good behaviors, washing hands regularly. If you feel unwell, inform the crew on the flight, on the ships, on the buses, and immediately, and avoid close physical contact with other passengers to protect the others. And then, of course, looking for the health information before, during, and after travel to understand the risk, a change of risks, and what could be the requirements at the borders. And then key facts about the Budibujo virus. Also, Dr. Patrick also mentioned in his slides. I think this is the science behind the virus. So it will help you to understand the travel advice, why we have this travel advice. Again, how it spreads, the person-to-person transmission are through the direct physical contact with the body fluids of someone who's sick or who has died from that disease. And the virus can spread through the surface and items contaminated by the body fluid, for instance, the clothing and the bedding. And what also very key message, I think that's it doesn't harm, we repeat this message. People can spread the virus only after symptoms appear. So asymptomatic traveler, a traveler who does not have the symptoms, they're not contagious. So with that, I think I will stop here, and thank you very much for the interest. Happy to answer the question. Thank you.
Thank you very much, Ninglang, for that very informative session. And I'm sure you've answered the questions of many people there who were wondering. Now, I'd like to invite Dr. Kai von Harbu. We've heard Patrick say how community ownership is the key. So he'll be talking about community protection as well as readiness measures for other countries. So Kai, the floor is yours.
Yeah, thank you. Thank you very much to Priya, and also thank you to Red, to Dr. Patrick and Dr. Ningland for those excellent presentations, and also thank you to everyone who is joining. I think we have well over 2,000 participants joining today, so it shows strong interest, of course, on this particular response, and also, of course, for EpiWin as our platform in general. As Supriya mentioned, my name is Dr. Kai von Harbu. I'm the Unit Head for Community Protection. And as we have heard today, from our regional emergency director and incident manager, and also earlier today and in the past 2 weeks from our director general, from our executive director, Dr. Chikwe. WHO is really putting very strong emphasis on the importance of placing people and communities at the center of preparedness and response efforts for this particular emergency. And this is a lesson from pretty much every prior Ebola outbreak. And because, of course, communities are the ones that ultimately decide whether our public health measures that we recommend and that we implement, whether these are accepted and trusted and ultimately effective. And this is why we at WHO have established community protection as one of the key pillars for this response. And in this short presentation, I will speak a bit to what this means in practice and how we are operationalizing this across the 3 levels of the organization. And here at WHO headquarters, community protection is a pillar in the IMST and includes these 5 core areas that you see here on the slide. Risk communication and community engagement. Of course, it's really key that people understand the risks and that they can take informed actions to protect themselves and their families. Then public health measures at borders, points of entry, and mass gatherings. And you heard a lot about that from Dr. Ninglan just before me, how to reduce the spread across travel routes, population movement corridors that we have very predominantly in this response as well. Then readiness actions, ensuring that countries that are at risk can assess their capacity and then identify gaps and take anticipatory actions before the first case occurs. And this is really what we put a lot of emphasis on, and I will speak a bit to that as well. And safe and dignified burial, it's a key intervention here, really respecting cultural and religious practices while at the same time preventing infections during the funerals. And the last one is operational and social science research, where we want to ensure that community needs and concerns and capacities and expectations remain at the center of all these response efforts. Next slide. And this slide really summarizes, and we will share this with you. I can't go into details because we are at the end already of the time for this webinar, so we will have to go a bit beyond today. But this really summarizes the package of support that WHO recommends countries to put in place under community protection, both for preparedness and response. And I just want to highlight 2 aspects here. Number 1, community protection also means considering social and economic effects of the outbreak. We know from many previous outbreaks, Ebola and others, that asking people to isolate or change long-standing practices can have significant social and economic consequences. And we need to protect, in particular, vulnerable groups and maintain essential services, use gender-sensitive approaches, etc., to address those impacts. And number 2, readiness and community protection are very closely linked. They are essential for controlling this outbreak and to prevent further spread. They both build on trust, on strengthening resilience, and to prevent outbreaks from escalating. And I will speak a bit more on readiness as well in this presentation. Next slide. Just to highlight a few of the community protection challenges that we see in this current response, and many of these challenges already have been mentioned by my previous speakers, and many reflect, of course, the complex setting that that this response is operating in, and many of these are very familiar from previous Ebola outbreaks as well. We continue to see misinformation, mistrust. We see resistance to response measures. When it comes to isolation, contact tracing, IPC, safe and dignified burials. For all of these, we see delayed care seeking and people that have fear of treatment centers and they fear the stigma associated with it. And of course, we have significant insecurity and access constraints that limit the response coverage in many of the areas. And finally, the social and economic pressures that I mentioned already often force families to prioritize their immediate survival needs over public health recommendations that we and the government are giving them. And of course, taking together all of these factors really have a massive impact on slowing detection and delaying response measures. Next slide. So what can we do to address these challenges? First of all, listening to communities. We need systems that capture systematically the community concerns, the rumors, the questions, the barriers to care, and ensure that information directly informs the operational decision making. Then we have to engage with trusted local leaders and networks, the religious leaders, the community leaders, youth, women, the community health workers in particular are very important trusted voices during an emergency. And we engage with all of these already across the 3 levels of WHO. We need to promote the early care seeking and reduce the stigma. We need to give clear information to the population that early diagnosis and treatment is improving outcomes and also helps protect the families and the communities. We have to ensure safe and dignified burials, and we have to use community evidence to drive all these actions. So community feedback, social listening, behavioral insights, operational research. This is key to ensure that the response measures are really responsive and grounded in local realities. Next slide. And of course, this response is really led by the governments of DRC and Uganda, supported by us, but we don't provide the support alone. It's a major strength of this response, the coordination. Sorry, next slide. I think we have to jump this slide due to the limited time. So I just want to highlight that strong coordination, the partnership through the collective service with our key partners, IFRC and UNICEF, and of course, Africa CDC that we are collaborating on. And you can see here some of the resources that we have already jointly developed, but also the collaborative approach is reflected in our joint continental response plan that was launched last Friday by Africa CDC and WHO. And this is also one of the events that we are conducting here to ensure that we inform and coordinate with partners. And we have many others of those here at headquarters level. We have CSO consultations, we have a collective service partner call, etc. So we are coordinating here the technical support, the community evidence activities, the resource development and the partner engagement. And we have developed already some key resources that we can share also in the chat. Very important is that we have developed harmonized key messages for this specific outbreak across the agencies that you see here to ensure that we really have a coherent approach to informing communities as a first step. And many other tools are currently in the process. Next slide. And now just to speak very briefly to readiness. Of course, we want to support countries through this approach to rapidly detect and investigate and contain any cases and outbreaks and prevent sustained community spread. And this is led, of course, by the African Regional Office of WHO. And we work very closely with AFRO and with the country offices, and through that also with our member states and partners in supporting these readiness efforts. We really follow a very systematic approach. And you can see here the prioritization of the different countries. We give, of course, particular attention right now to the neighboring countries, especially South Sudan. And I saw a question on that in the chat that I'm happy to respond to a bit more, but also Rwanda and Burundi, and also maintain readiness efforts across all the priority countries that you see here. And of course, readiness begins with understanding the risk and identifying gaps. So a readiness assessment has already been conducted in all these priority countries using a standardized checklist. There's a lot of contingency planning that is costed, already been conducted, and systematic readiness activities are ongoing in all of these countries. And now, of course, we have to move from the planning to the operationalization of those readiness activities on the ground. And here, key activities include activating and testing the EOCs, the incident management systems, strengthening the operational capacities across all the different pillars that you have heard already on today, including community protection, and then really reaching the subnational and the community levels with our preparedness efforts. This must reach all the districts that are at risk, the border areas, the health facilities, the communities and the community health workers, because that's where the outbreaks are detected and where the response is actually implemented. And this is really an effort of WHO across the 3 levels supporting this. Next slide. So just to conclude, I think I want to highlight 3 key messages. Number 1, communities are not the beneficiaries alone. They are the essential partners in preparedness and the response. Secondly, readiness must begin before cases are detected and must extend to the local level, in particular in these higher risk border areas and communities. And thirdly, as was mentioned already by Dr. Patrick, by Red, and by many others, trust is the most important public health intervention during an Ebola outbreak. We must invest in this community protection and readiness activities, strengthen resilience and reduce the risk for wider transmission. And this is not a one-off activity. This requires continuous presence. So, and trust must be built before the outbreak starts. It is a key readiness and preparedness activity. So we really need investment in this community engagement, in the community health workers as a kind of longer term activity, because this is also one of the most cost-effective interventions. And just to share that, to support this readiness globally beyond also those priority countries that we are focusing on now, we have launched the first Bundibujo virus disease specific course on OpenWHO, and you can see here the link to it. And I would like to encourage all of you to access the course and share it with your wider networks and institutions to really, and of course, many other courses are following in the following weeks. Thank you very much, and back to you, Supriya.
Thank you very much, Kai, and appreciate very much that you try to wrap up quickly, considering we've run well out of overtime. Although I have to say, all the presentations were so important and so interesting that I really didn't feel like interrupting. But it does mean that we have come to the end and we have very little time for Q&As. And that's a challenge because there are more than 100 questions in the Q&A. I don't even know where to start. So there's one, I mean, there are questions on transmission, on exposure, but there's one question maybe I will ask, considering this ongoing conflicts, population displacement and fragile health systems in some places, how is the outbreak responding and adapting where traditional surveillance contact tracing are difficult to implement? I leave it open. Who would like to answer this question? At least have a stab at it. Patrick?
I was going to give to Red to start if she's still online, but if she's not, then I can start. Okay, so we acknowledge that the context for this outbreak is a very challenging one, prolonged humanitarian crisis, insecurity, but we are trying to use a three-pronged approach for this. So one has been the issue of trust that Kai has talked about, building the trust with the community. In the last 2 weeks, there have been extensive engagement with different groups in the community. The youths, through the churches, through the mosques. The Red was meeting last week with the Society of Entrepreneurs and the motorbike riders, all different groups because contact tracing is one of the community-facing interventions. If you are not accepted in the community, you cannot go and move around and say you're following contact. So that aspect is the first one that's being done to make sure that we are on the same page with the community and they accept and they welcome these measures. The second one then is to bring on board the manpower that is required to conduct the contact tracing. So a number of the community healthcare workers have been trained the last few weeks to also equipped with the tools, even the means of transportation. Motorbikes have been provided so that they can be able to move around in different areas to access to where the contacts are, monitor them. So that has been an ongoing process to, as you know, in those areas, because of the number of contacts we have, over 5,000, you need also a high number of contact tracers to be able to follow them. And usually you will need like maybe 10 contacts per contact tracer in that kind of remote setting. So you need to be able to have adequate number, and that training has been ongoing with all the partners to roll out. The last one is then the issue of the security and access, because then if you have the community, you have the contact tracers, they're equipped, and what the security becomes the other impediment. And that is something that the leadership of the country, the leadership of the province has been engaged in to try to work with different actors that are there to ensure that there's access. Our regional director has also been appealing for a humanitarian truce so that in this period, because the virus does not differentiate from any political side or divide, that at this point where we have this conflict, that where we have this outbreak, at least the guns could be silenced so that the responders can access different parts of the provinces that are affected to conduct the activities that they need to do. So those are high-level political engagement, and security engagements are ongoing to ensure that we can facilitate access to the responders.
Thank you. Thank you for this very clear delineation. The next question, I know we're over time, but just a few more questions. I will put that, it's a gender issue, so I will ask Kai. Kai, you know, there's a question that says men are, badly affected, especially in the mining region, while we know that women are vulnerable due to caregiver roles they have in the family and community. Can you say that, is it the same dynamic in this outbreak? What do you say about the vulnerabilities? Over to you.
Yeah, thank you. Thank you very much. I think it's a very important question, but I think at this stage, we are still working with quite incomplete data. We have to acknowledge that, and I think it was mentioned earlier as well. And we need to treat this cautiously when it comes to conclusions, in particular about the gender dynamics. So I don't know if we can say that this is a general kind of epidemiological reversal, or this is just reflecting the specific context and the transmission patterns of this outbreak. But what you mentioned in the question already, the mining communities, the highly mobile populations, there may be some early transmission chains linked to these occupational exposures and these mobility patterns and social interactions, etc., that involve more men than women. But we also know from other Ebola outbreaks that women often face higher risks due to their role as caregivers within their households, but also their role as health workers, community health workers, and caring for sick family members and preparing bodies for funerals. So these risk factors, of course, remain very relevant here, and they can become also more prominent in the when the outbreak spreads further, when it goes into transmission networks in households and communities, etc. So I think we have to be careful with making assumptions based solely on the overall case numbers. We have to look at the context analysis, the transmission patterns by sex, age, occupation, etc. All of this is important, and this is why social science and behavioral insights and community feedback is so important in this response. And I think also the key operational implication of this is that we have to focus on gender sensitive interventions and interventions that are tailored to the local realities. This is what we try to achieve with this community protection approach that I was speaking to. And of course, then we have to adapt our efforts when it comes to risk communication and community engagement to the specific populations that are exposed and that are where the transmission is occurring. And that includes those occupational groups, but also mobile and displaced populations that we are focusing on a lot right now in collaboration with our partners, UNHCR, IOM, etc. This is another very important group to focus on. I think I leave it at that. Back to you, Supriya.
Thank you so much, Kai. I wish we could answer more questions, but we're well over time, and thank you for those of us staying on. But we will look at all your questions, and let's see if we can answer some of them and put it online so that we address your concerns. Now, before we end, from EpiWin, we have the tradition of asking something from you. So again, slido.com, #3952434. What was the most useful or relevant takeaway from today's webinar for you? I hope we still have more than 1,500 people online, so it would be great to hear from you very quickly. And we will leave the Slido open for the next 24 hours. We would really like to understand what was most important for you. Trust, collaboration is coming up very strongly. Preparedness, community engagement. Coordination, guidance, the situation update, ports of entry, but trust is coming out strongly. Okay, so this is open. We'd love to hear from you, but for now, I would like to thank all of you for joining us, participating, and some very nice insights, including a poem for community health workers. Thank you so much for that poem. Wonderful engagement, and really thank you to all the participants. I'd like to thank all the speakers, especially the Regional Emergency Director and Patrick, who made time in spite of the busy response. Really appreciate that. Thank you also to Ninglang and Kai, who've been also busy with the response at this level. Thank you very much for wonderful presentations. I'd also like to thank our interpreters, our IT support, and also my colleagues who've been working in the background, Brian, Michael, Armoral, and also our colleagues in Project ECHO, our collaborating center. With that, I hope to see you for the next EpiWin webinar, which is finally the last hantavirus in focus webinar, which is on 16th June at 4 o'clock to 5 o'clock. It's not the usual 1 to 2 p.m., but it's a 2 to 3 p.m. Webinar. And with that, thank you.
Thank you. Bye.
Thank you, everybody. Thanks, Patrick. Bye.
One last slide. We have a whole course on OpenWHO, which Kai had also shown actually. So please do go to openwho.org to learn more about the Ebola disease caused by Bundibugyo virus. And see you next week. Thank you.